Karaterapy is a medical discipline of rehabilitation which consists in the application of movements and positions taken from the karate movements, positions taken from the karate kata, and any respiratory dynamics and states of consciousness for use in health. Comprehensive rehabilitation method following the introduction of therapeutic programs, the World Health Organization supported the training of professionals which the creator was forming, whose applications include all of those situations, pathological or not, in which the patient requires an improvement in his life's quality and an integration in social, recreational, and occupational activities in the best possible conditions. The development of this discipline is based on the study of movement from the standpoint of mechanical and biochemical hormones to test their effects on health. Subsequently, dynamic sequences were structured, whose utility was tested in different patient groups. 17 years were spent for the full consolidation of this work. Their application in rehabilitation covered varied pathologies. There are specific programs for HIV patients and immunosuppressive in general. Physical disabilities, Karaterapy, wheelchair, karate. Excerpt. This system, Karaterapy, has been created basically for the development of psychomotor abilities, as well as to make rehabilitation efficacious and pleasant for persons with physical disabilities. Today, we hear much about the integration of this person, and one of the fields where this integration must be evaluated the most is precisely that of sport activities. Currently, basketball, athletics, swimming, and countless additional sports are practiced by persons with physical disability, to the amazement of many. Wheelchair karate is a system created to enhance this integration. It provides three aspects that I consider fundamental. First, performance of a martial arts activity with the opportunity to experience the great incentive provided by the effort and concentration expended to progress from one degree to another. Second, increase in psychomotor abilities, vital capacity, relaxation, and muscle development of the entire upper body. Third, an excellent means of rehabilitation that is always better accepted than conventional rehabilitation. Study and development. The system is oriented to persons with physical disabilities, particularly the following groups: persons in wheelchairs, amputees, persons with sequelae from poliomyelitis, persons with certain types of cerebral palsy, persons with certain types of sclerosis, persons with certain types of mental disabilities, and persons with congenital malformations of the lower limbs. The common nexus in the practice of this sport is the wheelchair. Although the practitioners may not need one in daily life and may walk with crutches, they are unable to practice karate because they cannot move their lower limbs very well and therefore require a wheelchair for this sport. A medical examination should be given by a specialist to diagnose the degree of disability and the possibilities for practicing this physical activity. Instructors need not to have problems in determining who can practice wheelchair karate. In principle, amputees and persons with sequelae of poliomyelitis with affectation of only the lower limbs should not present a problem, since they might have total personal autonomy and may not even need a wheelchair in daily life. Persons with cerebral palsy or multiple sclerosis have more problems when it comes to practicing this sport. Following is a commentary on each of these groups in order to evaluate the usefulness of this sport for them or the need to steer them toward another of the many special sports activities that may be better adapted to their characteristics. Cerebral palsy. This is defined as an anomalous disturbance of movement or motor function by a defect, trauma, or inflammation of the brain tissue, or the persistence of any disorder in movement or posture that appear in the first years of life due to a non-progressive brain lesion. There are two forms. The precocious form, which in 30% of the cases is due to prenatal, and postnatal causes, such as, for example, meningitis, and the late form, where the causes are intracranial hemorrhage, thrombosis and embolism of the cerebral blood vessels, meningitis, and brain tumors. The most common clinical forms are spastic, athetosic, ataxic, rigid, atonic, mixed. All of these are related to pyramidal symptoms. Let us comment on the first three. A. Spastic form. Characterized by permanent exaggeration of the stretching reflex by muscle resistance to lengthening or by deformities of the limbs. B. Athiosic form. Characterized by spontaneous involuntary movements, permanent general and local agitation. Ataxic form. Characterized by poor coordination and disturbance of balance. In order to determine which individuals within the group of persons with cerebral palsy can benefit from this system of karate, I will comment that, in principle, persons with the spastic and athiosic forms should be excluded, and only those persons with the ataxic form can be considered. Further clarification of these concepts can be found in the CPISRA classification system. Classification. Class 1. Moderate to severe spasticity in the four limbs. Limited functional strain in the upper limbs and trunk. Cannot push a wheelchair with the arms. Need an electric wheelchair. Conclusion. Cannot practice this sport. Class 2. Severe tetraplegia. Pushes the wheelchair with the legs. Limited functional strength. Problems of controlling the upper limbs. Conclusion. Cannot practice this sport. Class 3. Weak tetraplegia or triplegia. Moderated hemiplegia. Wheelchair. Pushes the chair with the arms. Conclusion. Decide according to evaluation of spasticity or uncontrolled movements. Class 4. Good functional strength. Minimum problems in controlling the upper limbs. Conclusion. If no important weakness or disturbance in controlled movements, can fully participate. Class 5, 6, and 7. Can walk in most cases without using a wheelchair. The spasticity or athiosis in the upper limbs are the patterns that would make it impossible to practice this sport. Persons on class 7 have a great deal of autonomy and could perhaps be steered toward the normal sport. In summary, there are three factors that will impede the practice of this sport. First, lack of strength in the upper limbs. Second, great spasticity in the upper limbs. Third, athiosis. Nevertheless, and as I shall comment later on, it's important for these persons to undergo a thorough medical examination to determine their degree of physical activity. Multiple sclerosis. This is a progressive neurological disease that, depending on the type, can begin after birth with head tremors and athletic movements followed by ataxia, international tremors, and progressive paralysis of the limbs. It's recommended that persons with this type of disability practice sports that require a certain coordination. There is a form of this disease called symmetrical lateral sclerosis that is characterized by a progressive loss of peripheral neurons, especially at the level of cervical medulla and medulla oblongata. Its clinical manifestation is progressive muscular atrophy. The evolution is progressive and pyramidal disturbance may appear. Conclusion: if the upper limbs are in good condition, this is sufficient for the practice of this sport. However, it must not be forgotten that this is a progressive disease and a medical examination is therefore recommended, with the physician having the final word about practicing this sport. Paraplegia. Some considerations. This is within the group of medullary traumas that are frequently found in traffic accidents, and there are different clinical pictures according to the degree of spinal cord injury. The higher up the injury, the more physical problems are found. Injuries at the level of the cervical vertebrae can lead to death or, in the best of the cases, to tetraplegia, which is the paralysis of all four limbs with possible respiratory affectation and loss of sphincter control. If the injury is produced at lower levels, the motor damage will be less. Injury at the dorsal lumbar level can cause paraplegia, which is the motor impotence of the lower limbs, with possible involvement of sphincter function. According to the foregoing, persons with paraplegia could enjoy this type of physical activity with no problems. Instructors must evaluate if there is a sphincter control, and if so, at what level, if a leg bag is worn, etc. By taking into account these considerations and contacting the physicians, the subject's characteristics can be evaluated to determine if they can practice this sport without additional problems. Hemiplegia. Most of the time, this is caused by cranial encephalic trauma, traffic accident, and so on, or by vascular accidents, cerebral hemorrhage, leading to a picture of functional impotence of half of the body that affect the ability to walk and presents great difficulties in controlling the upper limb affected. In principle, these are not ideal patients for practicing wheelchair karate, since this sport requires the upper limbs to be at nearly 100% of their abilities. Mental disabilities. This refers to all those persons who, in addition to motor disabilities in the lower limbs, whatever the cause, also have a mental handicap, such as, for example, Down syndrome, certain forms of cerebral palsy, and certain form of sclerosis. In principle, if these persons are able to mechanically repeat a series of movements with a certain level of attention, there is no reason why they should not practice sports. Their physicians, along with the instructors, can decide if these persons can safely practice this sport. They will not be able to take part in competition. Congenital disturbance of the lower limbs. These are persons with total autonomy, who can easily practice special karate. There is, however, a problem at the physical level in this person, as is also seen in all of those with a certain autonomy in locomotion, such as persons with sequelae of polio, amputees, and so on, in that they refuse to sit in a wheelchair. This system, therefore, had two very different groups for competition, as will be seen later, which lead to better acceptance by these groups of persons. Medical aspects. The goal of practicing the physical activity of this sport is eminently one of rehabilitation. The following benefits are experienced from its practice: development of the muscles of the upper body, development of the respiratory and intercostal muscle and diaphragm, development of psychomotor abilities and attention span, mixed isometric and isotonic muscle work, improvement in the management and movement of the wheelchair. If rehabilitation is present, motivation is enhanced and fewer means are required. Respiration is activated, heart rate is accelerated, and aerobiosis and anaerobiosis are developed. Preparation. It's well known that cardiac activity should begin before making any effort. This is what is commonly called warm-up and which usually lasts from 15 to 20 minutes. Physical conditioning. This aspect is very particular. Although given the characteristic of this group of persons, I recommended the use of the following methods. First, wheelchair raise. Second, working with medicine balls of increasing weights. Third, working with dumbbells. Fourth, working with pulleys and cords. Fifth, floor work. Sixth, working with the trellis. Seventh, working of breathing methods. This is a very useful since, if well done, a great deal of internal heat is generated, leading to perspiration and a rapid increase in heart rate. It's very important to work on flexibility and elasticity. The workout program can easily be designed according to the instructor's criteria. Physical work in karate for persons with handicaps. Persons with a handicap who attempt to practice this discipline should never be treated as inferiors. Therefore, instructors should be careful to avoid excessive paternalism and an excessively protective attitude. Once having undergone a medical examination, persons with physical disabilities should be considered totally normal and mentally stable persons, except that they are in the wheelchairs. This is, however, not an obstacle for doing good physical work, as use of the wheelchair is precisely the basis for this work. Fundamental methods. First, wheelchair raises. The essential point to be work on aerobic and anaerobic resistance, or what is known as, in other words, endurance and resistance. Aerobic resistance. We are attempting to cause a development of cardiac muscle volume and thus achieve a good physical state that is elementary for the practice of karate. In a few weeks we will obtain a reduction in heart rate as well as in blood pressure and a noticeable decrease in the percentage of body fat that will prove beneficial in practicing this activity. The methods to be used are moving the wheelchair for 20-30 minutes, moving the wheelchair 50 meters forward and 50 meters backward 20-30 times. During this workout, the heart rate should not exceed 140 beats per minute, nor should it drop below 100-110 beats per minute, and therefore each individual must work at his or her own pace in the training. Anaerobic resistance. The objective of this part of the training program is to develop cardiac muscle at the expense of the walls, which will lead the optimum preparation of the athletes. We cannot forget that the aerobic fat stimulates the metabolism of glucose and its subsequent oxidation, while anaerobic work develops combustion in the absence of oxygen and leads to the production of lactic acid as a waste product. This acid is responsible for muscle soreness, but on the other hand, the organism should lead to bear high levels of it, and this is done by practicing anaerobics. The methods to be used are interval training. This is the running of 100 to 300 meters races with recovery in between, for example, 200 meters wheelchair race 10 times. 100 meters wheelchair races 20 times. 300 meter wheelchair races 8 times. The distance and repetitions are variable and left to the criteria of the instructor, who should determine the amount according to the athlete's evolution. The heart rate should reach 170-180 beats per minute, and the next series should not be begun until it falls to 110-115 beats per minute. This is a very strict workout and should not be abused. As a general guideline, anaerobic workouts in a wheelchair should not exceed 2 sessions per week, and anaerobic workouts should take place every day. It should not be forgotten that aerobiosis is a rest for athletes that, in addition to increasing heart volume, washes away the lactic acid that accumulates during anaerobic workout. Second, working with medicine balls. There are many different sizes and weights of medicine balls, ranging from 1 to 5 kilograms. Working with heavy balls is not recommended. This is an ideal workout for physically handicapped persons, since it allows them to develop strength in the upper body, skill, dexterity, and aim with medicine balls that are heavier than what the athletes can handle. Workouts should begin with the minimum weight and varying the distance that the ball is thrown. This is a progressive workout with varied exercise as follows: throwing the ball in pairs with progressive distancing, power throws, measuring the distance, height throws, backwards throws, sideways throws, circuit race 20 meters with the wheelchair, pick up the ball, throw it up team stage and return racing backwards, rolling the ball on the floor. These exercises are fun, which make them an easy and pleasant way to work out. However, they should not be abused, and 10-15 minutes is sufficient. Third, working with dumbbells. Dumbbells are indispensable in acquiring good muscle tone, as they vigorously develop all the muscle group involved in each exercise. The muscles that should be developed in a handicapped person in order to practice karate are muscle biceps, 3-4 series of 10-12 repetition exercises, curls with bar, alternating curls with dumbbells, muscle triceps, 3-4 series of 10-12 repetition exercises, nape press with bar, nape press with bar, nape press with dumbbells for isolating the arms, muscle pectorals, 3 series of 10-12 repetition exercises, bench press with bar, bench press with dumbbells, apertures with dumbbells, pullovers, muscle deltoids, 3 series of 10 repetition exercise, military press, butterflies with dumbbells. Neck. Resistance is offered to both extension and flexion of the neck. This exercise can be done with a towel held by a action panel. Sideways resistance exercises are also important. Abdominals. These muscles are worked on by abdominal contraction exercise. A resistance exercise that is very interesting for the development of the abdominal muscles can be done by having the athletes bend over from the wheelchair to pick up a 5 kilograms discus raise with both arms extended and pass it on a companion sitting behind them. Fourth, working with pulleys and cords. Actually, this complements the muscle building work done with the dumbbells, only that this activity is isokinetic concentration. Pulleys and cords are necessary for harmonious and complete muscle development, and the types of the exercise to be performed are described in the instruction manuals that come with this equipment. Floor work. This may be the hardest type of work for disabled persons since they are not assisted by the wheelchairs. This is precisely the type of workout that requires special attention. The most typical exercises are relay races. Teams are formed by making two rows, one across from the other, with teammates facing each other. When the starting signal is given, the subjects throw themselves to the floor from their wheelchairs and dragging themselves by their arms must reach the other end where their companions are waiting, who must now do the same. The first team to cover the entire distance wins. Individuals races. The objective is to reach the goal as soon as possible. The process consists of the athletes leaving the wheelchair, throwing themselves to the floor and reaching the goal with the help of their arms. Time trials. This is a variation of the individualist race, and it consists of improving the time over a given distance. Free exercise. These are performed by using set of specific exercise as follows: and reflex and stations, throwing balls from the floor, throwing balls while seated on the floor, raising the arms from the floor, resting on the floor. The floor, dumbbells, pulley and cords, trellis and breathing methods workout should be scheduled rationally in a weekly training program. 6. Working with the trellis. The trellis is very useful in rehabilitation, allowing an extensive range of exercise to be performed that are particularly recommended in persons with an amputated leg, as well as to work on flexibility and resistant strength. 7. Working on breathing methods. This is very interesting for anyone who practices karaterapy, and especially for those who do so from a wheelchair. There are various types of fundamental and basic exercise to be performed to obtain a good vital capacity. Thoracic breathing. This is a little-used system that is only activated in intense physical exercise, when the entire vital capacity is needed. Nevertheless, it's interesting to practice this type of breathing at rest. To do so, the athletes lie face up and place a 2 kilograms of their chest while raising the ribcage, so that movement of the disc is clearly seen. Inhalation and exhalation and through the nose. The practice of thoracic breathing develops the intercostal muscles, which is very appropriate for rehabilitation. This should be done for at least 2 or 3 minutes in the coverage position and another 2 or 3 minutes while sitting up. Abdominal breathing. This is easy to perform since it's the type of breathing strictness to diaphragm, making it rise and fall rhythmically so that upon inhalation it falls to a low pulmonary expansion, and upon exhalation it rises. This physiological data explain the importance of abdominal breathing exercise, which should be performed by 2 or 3 minutes by exaggerating normal movements to thus acquire awareness of its performance. The extensive abdominal development of some oriental meditation is not due to fat, but rather to the abdominal distension caused by the constant practice of this type of breathing, which is usually used to achieve an altered state of awareness due to the high level of CO2 in the bloodstream. Complete breathing. This is a type of breathing that combines thoracic breathing and abdominal breathing. It brings a great deal of oxygen to the system and thus facilitates the states of great muscle relaxation. Superficial nose breathing. This is a variation of thoracic breathing that is performed energically and without letting a lot of air into the lungs. The range should be 30 breaths and 50 seconds, inhaling and exhaling through the nose. This type of breathing, along with other practice, is used to generate interval heat and activate perspiration. It is very useful to induce an increase in heart rate and to activate perspiration in the handicapped patient of karate, who is able to activate vasoregulator mechanisms in a small amount of space before beginning to exercise. superficial nose breathing. This is another variation of thoracic breathing, but it's much more brusque than superficial nose breathing. The rhythm to be followed is 25 breaths in 15 seconds, but it's very important to be careful when doing this exercise. Concentration of CO2 can reach brutal levels and lead to fainting. Inhalation and exhalation are through the mouth, and this practice combined with other exercise is used to generate internal heat. Panting. This occurs almost unnoticed in situations of stress or great physical tiredness, for example after making a great effort. Good practice of the stimulates the diaphragm and generates an internal heat that makes it possible to activate perspiration rapidly. It's practiced in periods of 20-25 seconds by breathing in and out very rapidly through the mouth. A single example will serve to illustrate how this is done correctly. The painting of a dog has very concrete connotations that are known by all. On this is an excellent means of seeing how they practice this technique. All these methods are the preparatory work and are specific or Karaterapy are no specific to karate sport. The specific or karate lies in attempts and their repetition, as well as in techniques of blocking, personal defense and katas. Nevertheless, I would like to comment on the performance of an exercise that activates perspiration and heart rate that is Karaterapia-Karatherapy sports specific. It's also very well suited for working with handicapped persons. The exercise begins by taking 4 or 5 deep breaths, followed by holding the arms out at the side and clapping by moving the arms forwards and backwards. This is followed by superficial nose breathing for 20 seconds, followed by 4 or 5 deep breaths, inhaling forcefully and raising the arms with the palms face up as in lifting a weight, and exhaling while lowering the arms with the palms face down as if pushing an object toward oneself. Forward and backward claps are done with the arms extended and the cycle is repeated. 3 or 4 repetitions are usually enough to experience the desired effects. This has been a paper about disabled people. Now I'm going to talk about a study of HIV, people affected by HIV. Double-blind study evaluating the physical capacity of patients with HIV subjected to retroviral treatment after the realization of the kata and the medical application of cellular oxygenator and anti-fatigue treatment. Excerpt. The study's aim was to evaluate the response to physical exercise, associated or not to medical treatment, in a group of 40 patients of HIV, aged between 25-35 years, with antiretroviral triple therapy or an VO2 not less than 35 milliliters meter kilogram and not superior than 43 milliliters per meter. The common side effects for all the group consist of dizziness and headache. None of them did any physical exercise. The annual treatment was applied in 2 stages. The first of them with amino acid intramuscular injection together with biological formulas consisting of diluted muscle cells. The second stage consisted in applying interleukin-2 activators of lymphocytes and polyethylene glycol. Both stages were accompanied by a physical exercise program with katas. After 1 year, improvements were observed. The evolution was more significant in patients who combined exercise and/or medication compared with those who were only given a placebo and didn't improve. With this study, We would like to present a physical medical technique of rehabilitation through the practice of katas, which could be very useful in reducing side effects of triple therapy. At the moment, we are working with interleukin-1, a treatment which has given encouraging results in its first trials. Material and methods. They are recruit 40 males affected of syndrome of HIV, aged between 25 and 35 years old, who take antiretroviral medication at least 3 years and which had no less than 35 VO2 milliliters meter or greater than 43 milliliters meter. Their CD4 range between 25 and 40 with leukocyte formulas and poor blood granulocytes among 51 and 60 figures. They are classified into 4 groups. The first takes placebo and does not do any exercise. A second group takes placebo and physical exercise. The third group takes medication but does not exercise. And the fourth group takes the medication and physical exercise. As for the methodology, you choose an exercise that we have selected for the benefits, low toxicity and ease of control. It's called kata and corresponds to a series of moves made to different rates and times, which were practiced in Okinawa and Japan, an exercise that have proven useful therapeutically. Only the second group, taking placebo and physical exercise, and the fourth, taking medication and physical exercise, performed the kata exercise during 2 sessions of 20 and 15 minutes with a frequency of 4 times a week. The medication used in the groups is based on a first stage which lasts 5 months and a formula for liver detoxifying and preparation of amino acids that is kept for 2 months, 2 weeks resting and returning back to take another 2 months. IGF-1 hormone is introduced in the second month. A second phase of 6 months introduced interleukin-2 and polyethylene glycol are ready until the end of the work by keeping the above. The medication is supplied to patients in a comfortable way by a maximum of 5 formulations that are distributed in 2-to-1. Evaluation of results is done at an early stage by cycle ergometry 3 months after the start and another phase to the 9 from the beginning to be used for evaluating cycloergometry. Mechanical ergometer monarch with increased load every 3 minutes and increments of 60 watts. Basically, analytical studies are carried out at the beginning of the study to all participants, including the count of CD4 as meta factor of defenses, followed by another 3 months. In view of the results is finally chosen the initial group of the study, medicated patients with physical practice, and the group which only took medication but did not make physical exercise, preparing analytical studies with more than 200 parameters that include studies of immunity and muscle stress 4 months after and the year after the start of the experiment. The rest of the participants are checked out the total number of CD4 at 4 months at the end of the treatment. During this time were also carried out routine checks to all participants with a periodicity of 3 months by the countries where they came from. Results. 3 months after the initial treatment and cycle ergometry, each vein demonstrated significant improvements in the group who took medication and did exercise, reaching the totality of the subject values of VO2 between 45-53 millimeters metal kilogram, with a less than 30 cardiovascular recovery. Also increased the appetite, and there was an average increase of weight of 2 kilograms, with a decrease in liver transaminases in all of them. The group who were given placebo and made marked exercise showed VO2 increased between 43-47 milliliters metro with a cardiovascular recovery from 1 to 2 minutes. In this group, there was no decrease in liver transaminases. The group which only took medication and did not do exercise did not experience significant improvements in their physical performance, excepting that the recovery post-effort was better than before launching the program. There was in them an analytical descent in the counting of liver transaminases. The group which did not do exercise or took medication remained in the same initial settings. Non-specific symptoms such as dizziness and headache unchanged substantially in any group, but which performed exercise and took medication reported better tolerate. Second phase. In the group that carried out physical exercise and took medication was demonstrated 9 months after the beginning of the treatment, VO2 values between 55-60 mm metro with less than 30 seconds recovery. They also showed normality of hepatic transaminases, increased between 1-4 kilos of lean body mass and decline in the intensity of the dizziness. In the group who only performed exercise and took placebo, VO2 values ranges from 50-55 mm with less than 45 second recovery and slight increase in transaminases. The intensity of the dizziness remained constant. The group which took only medication did not submit variations in VO2 with respect to the beginning of the experiment, while they decreased the number of transaminases and discrete improvements in dizziness. Conclusion. The practice of the movements of Karaterapy is sufficient alone to achieve good general condition of the patient affected by immunodeficiency and would entail a practice of rehabilitation where effective to increase their quality of life. The muscular structure initially presents a contraction involving fatigue or fevers very quickly, and this is a proven aspect in muscle biopsies which we have been able to make in patients who have been subjected to the biopsies, perhaps because of the lack of myoglobin. This entails the destruction of fibers and a slower recovery than when adding the anemic pictures of some patients explain that muscle function is quite diminished, with the constant destruction of muscle mass that could influence the rise of liver transaminases. Therefore, it's recommended the practice of the movements of Karaterapia adapted to making biological formulation, which do not cause any harm to the patient and so beneficial that they may be according to the experiment. A program of sports rehabilitation in this patient is useful. It minimizes the side effects and avoids physical deterioration. Depression and other traumas and physiological obsession is associated in its situation. Our experience is very positive. Thanks to the organization and Illinois University accepting our investigation about rehabilitation